Hello classroom. In today's class, we are going to be having a short presentation, and the module that you shall take this topic from is going to be the apprenticeship in internal medicine. So before this pandemic came in and before the closure of college, uh, previously told you about what you are going to be covering in apprenticeship in internal medicine, and by the matter of fact that this pandemic is not going to end today, it's better to continue learning by this process of e-learning or distant learning. And people should not be afraid of these methodologies, because many people have used this. The Open University of Tanzania is using this methodology, and people graduate, become big people in this nation. So people should not be afraid of this e-learning process or distant learning. So like I told you earlier, in apprenticeship in internal medicine, we shall be covering plenty of topics, and here are some of the summary of the sub-enabling outcomes. So we have some hemato-oncological conditions, we have neuroendocrine conditions here mentioned, we have genitourinary conditions, we have gastrointestinal conditions, we have dermatological conditions. So in today's session, we shall be covering about the dermatological condition, which are mentioned here in this sub-enabling outcome. And in further video tutorials, we shall be covering other parts. So keep in mind that you have to cover all these contents when you come in level 6 semester 2 apprenticeship in internal medicine. So like I said, or like I introduced in this chapter, we shall be covering the dermato-oncological conditions. So my name is Victor Njunwa. I'm a medical doctor and a tutor at Bumbuli Clinical Officer Training Center, NTA L6S2 2020. So when we talk about dermatological conditions, first thing first, dermatology is, as the name suggests, the word derma means skin and logy means study. So in dermatology, we study the disease conditions. Yeah, we study the disease that affect the skin. But it's not only that we cover the skin condition. We also cover conditions that affect the skin appendages. And when we talk about the skin appendages, we mean the nails, we mean the hair. So it's very unfortunate that in our curriculum, most of the things that we are going to be covering will only be focusing on the skin and not the other appendages. So skin with other these these appendages, all these together form a thing that is called the appendicular system. So remember, the appendicular system involves the skin, hair, and nail, and all these components are well studied in dermatology. So our curriculum requires us to learn these following disorders. We have eczema, we have vitiligo, we have acne, we have psoriasis, and Kaposi sarcoma. So the course outline of this presentation is going to be divided. First is we shall be going to discuss about the terminologies that are used in dermatology. Because for you to come up with a proper diagnosis of any skin disease, you need to understand the terminologies that are used in dermatology. Otherwise, we shall also be going to discuss about the causes and risk factors, epidemiology, clinical features, diagnosis and provisional diagnosis, pre-referral management, follow-up, control, and preventive measures against these skin disorders that I've shown you. So let's begin with the dermatology language. So the terminologies that are used in dermatology. So before we begin, we need to remember one thing, and we need to recall one thing that we studied in anatomy, that the skin is made up of three parts. So the skin is an organ that is made up of three parts. I hope you all know this, that the skin is an organ. It is made up of the epidermis, dermis, and the subcutaneous layer, or sometimes called the subcutis. So we shall be talking about the epidermis in the next slide, but the other issue that I want you to remember is this called the pyrosebaceous unit. The pyrosebaceous unit is made up of the hair follicle together with the sebaceous gland. The sebaceous gland produces sebum on top of the skin, and this sebum is sometimes used as an antibacterial agent on the skin, but again it lubricates the skin, prevents it from becoming hard, but it also prevents from evaporation of water from the skin. So remember, this is the pyrosebaceous unit, and this is one area where one disease can arise, more especially when this sebum or this oil that is produced from the sebaceous gland gets blocked. It doesn't get out from this sebaceous gland. It is going to bring about a disorder that we shall be talking about in the next presentation. The other issue that you need to know in this presentation is about the 5 layers of the epidermis. From top to bottom, we have the stratum corneum, we have stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. I'm trying to talk about these 5 layers of the epidermis because normally the epidermis is in a renewal process. The epidermis normally gets washed off after every 28 days. The skin might get off, and this process is more prominent in those people who are in young age. But as you age, this process of skin renewal gets down. So as the skin tries to renew this epidermis, in some conditions this renewal process is going to end up forming some scales, and some scales here on the top of because there is abnormal peeling of this epidermis during the renewal process. So the other language that you need to understand when you talk about dermatology is the primary skin lesions. So we have skin lesions. The skin lesions can either be primary skin lesion, but they can also be secondary skin lesions. So let's begin with primary skin lesions. As the name suggests, means these are very specific to a particular disorder, unlike as the name suggests, secondary. Secondary means, for example, your skin is itching. So if your skin is itching, you will try to scratch yourself. Utajaribu kujikuna. So as you scratch yourself, you will form some linear ulcers or erosions, which are called excoriations. So excoriations are secondary skin lesions because they started as a itching skin lesion, which is a primary skin lesion, and ended up into excoriation after scratching, and we call this a secondary skin lesion. So I hope you understand these two terms when we talk about the primary skin lesion and the secondary skin lesion. For you to come up with a diagnosis of any dermatological disorder, you need to know these primary skin lesions, but you also need to know these secondary skin lesions. So to begin with, let's begin with a primary skin lesion called a macule. Now, a macule is a circumscribed flat area of skin of less than 1 centimeter in diameter that appears different from the skin surrounding it, usually because of a different color. So this is a macule. We're going to be seeing some diagrams, but underline these few words. It is circumscribed flat area of the skin, less than 1 centimeter, and it appears different from the skin surrounding it, and usually because of different color. So when a macule is greater than 1 centimeter, then it is not called a macule, it is called a patch. The other term that we have in dermatology is a papule, and any skin elevation of the skin less than 1 centimeter and it is palpable is called a papule. For example, just assume when you are having this acne, in Kiswahili we call it chunus. When you're having a chunus, you will feel like something on your skin is elevated, and if you try to palpate, that elevated skin lesion will be palpable. So we can call this a papule. So remember, it is less than 1 centimeter. So diameter matters. If it is greater than 1 centimeter, then it is known as a nodule. But the other term that we have is also a plaque. Now a plaque is a raised area, skin with a flat top. Now underline these words, flat top, greater than 1 centimeter. Now remember, a papule was also a raised skin lesion, and it was palpable. But in a papule, the top of the papule is not flat. So anything that is having a top, kwa juu panakuwa flat. Anything that is flat, then it is a plaque. But also we have a vesicle and bulle. A vesicle is a fluid. A vesicle or a bulle is a fluid-filled blister. Now what differentiates a vesicle and a bulle is only a diameter. When the size is less than 1 centimeter, then it is a vesicle. And when it is greater than 1 centimeter, then it is called a bulle. The other issue that we have, very important, is a visible accumulation of pus in a blister. So remember, a vesicle is clear fluid filling this vesicle, but in a pustule it is pus in a blister. So always remember these terms. The other important, I'm not going to be talking about abscess, barrow, because we are not going to be coming across any disorder that talks about this, but let me try to explain the comedone. Now the comedone is a plug of keratin and sebum in a dilated pyrosebaceous orifice. Remember, we talked about the pyrosebaceous unit, which comprises the hair follicle together with the sebaceous gland. So when this pyrosebaceous duct or orifice become blocked with keratin and sebum, we call this a comedone. We are going to be talking further about the comedone. We have two types of comedones when we talk about the disease called acne. The other issue that I want to talk about is the scale. And a scale is a flake arising from the stratum corneum. So you remember the layers of the epidermis. Let's try to go back to these layers of the epidermis. So you can see one of the layer of the top layer of the epidermis is called the stratum corneum. Now when this stratum corneum peels off, when it peels off, kama inajimenya hivi, ikijimenya hivi ndio tunapata kitu kinaitwa scale. So a scale is a flake. When you say flake, is like something that has peeled off from the skin, arising from the stratum corneum. Any condition with a thickened stratum corneum, so any condition that will bring about thickening or enlargement of this stratum corneum, that is through the process called hyperkeratosis, will cause this thing called scaling. Now here are some of the pictures trying to show the primary skin lesions. As you can see, this is a comedone, and this you can see it's black here, though you can also have a white comedone, but it's black here because we should explain anyway. We should explain about this. Why is it black when we talk about acne? As you can see here, we have a surrounding skin, which is maji ya kunde, but we also have a certain area which is not raised actually, but it has a different color as compared to the surrounding area, and we defined this as a macule. So I will try to explain those common terms that we are going to be using. I skipped the barrow, I've skipped the papilloma, but let me talk about the papule. So as you can see, we defined a papule as a raised. A papule is a elevation of a skin and is palpable. So as you can see, and it must be less than 1 centimeter. So as you can see, this is the raised skin lesion and it's palpable, obviously. The other issue that we have is the plaque. As you can see, a plaque, as you can see, it's raised, as you can see, but the top area of this raised region is flat. So remember, the definition of a papule and a plaque are almost similar, but the difference came that the top part of a plaque is flat. So this is the difference between a papule and a plaque. But the other term that I want you to understand is the scale. As we said, that through the process of hyperkeratosis, Hyper means too much. Keratosis means too much production of keratin. So keratin is that top layer of the skin. So when it becomes too much produced through the process called hyperkeratosis, the stratum corneum tries to peel off so as to reduce this thickening. So through this peeling of the skin, we get a skin lesion called a scale. I'm not going to talk about the telangiectasia and weir this time, and probably I will show you an example. The vesicle is self-explanatory. The other skin lesions, type of skin lesions that we have. Now, before we proceed with the secondary skin lesion, let's try to go through these examples. Now, I have 4 images here trying to test your knowledge if you really understood these previous slides. So, guess what is this skin lesion? Anyone who can guess this skin lesion? If you are saying a plaque, then you are right, because if you look at this skin lesion is raised and the top part of it is flat. But if you are very smart enough, if you are having a good doctor's eyes, you might see that this top part is having scales. So this is a plaque with scales. Next, on the right, this is very obvious. It is raised, it is fluid filled, but how many centimeters? Probably greater than 1 centimeter. So if it's greater than 1 centimeter, we call this a bure. If it were less than 1 centimeter, then it's a vesicle. There down, left down, we have this hyperpigmented. It is hyper means this area is pigmented too much as compared to the surrounding skin. So we call this a macule. If you remember the definition of a macule. Let's get back. It's a circumscribed flat area of skin less than 1 centimeter in diameter that appears different from the skin surrounding it, usually because of different color. But remember, was that image showing skin lesion with less than 1 centimeter? We shall come to see. If it's greater than 1 centimeter, then it's not a macule, but rather it's a patch. So, is it 1 centimeter or less than 1 centimeter? Let's say it's greater than 1 centimeter. So probably this is a patch. So left here, we have a raised skin lesion, which is palpable, but it's not flat. Then probably this is a papule because it is less than 1 centimeter. So I hope you understood the primary skin lesion. But we also have the secondary skin lesion, and here I will try to I already explained this term exfoliation. Let's first begin with the crust. Now assume this blister bursts. If this blister is filled with fluid, this fluid is going to dry here. If it dries, just assume like a pustule. Suppose this was a pustule filled with pus. If this pus will dry here and it transform a color as if it were gold. Kama umewahi kuona usaa umepasuka, ukikauka unaonekana kama una rangi ya gold. So that dried pus is called a crust. So it can also be blood, but a crust is a dried exudate of blood or serous fluid. So if it is serous fluid, then it is going to be golden in color, but if it's blood, then it is going to be red dried. We call this normally crust. But you also have exfoliation that we already explained. For example, most of the skin conditions that we shall be talking about in this presentation, they normally prompt a person to scratch oneself. So if one scratches oneself, it can form some linear ulcer which are called exfoliations. But through this process of scratching, the skin will try to thicken as a defensive mechanism. As this skin thickens, it will form a phenomenon or a secondary skin lesion that is called lichenification. I've tried to skip other skin lesion, and you will read this on your own, but I'm trying to explain those skin lesions that we shall encounter when we talk about the pathologies. The other term that you need to know is the cyst, and the cyst is a soft, raised, encapsulated lesion filled with semi-solid or liquid contents. The definition of this normally looks like it was vesicobure, but remember it is filled with semi-solid or liquid contents, not necessarily to be liquid, it can also be semi-solid contents. But the other issue is that this cyst is normally encapsulated, it's having a capsule, ni kama kamfuko fulani kamefunika hizi contents zake, whether semi-solid or liquid contents. The other term that I want you to understand is the pruritus, and pruritus simply means is a sensation that elicits the desire to scratch, yani unakuwa na hamu ya kujikuna, then that's what we call pruritus. So let's begin with the first dermatological condition, which is eczema. So the other name for eczema is dermatitis, and as the name suggests, dermatitis, any word ending with itis means normally is signifying inflammation. Mostly it signifies inflammation. So dermatitis is inflammation of the skin. So the word eczema and dermatitis in some books are used interchangeably, but eczema or dermatitis is a pattern of inflammatory response of the skin. So as we said, it's an inflammatory response of the skin, and normally it is characterized by erythema. And when we talk about erythema, we are talking about reddening of the skin. If the skin becomes red, like if you go back to some skin lesion, for example, this, if you look at this skin lesion, it is much red than this one here, so you can call this is erythematous skin lesion. But if you also look at some skin lesion like this one here, the surrounding region is much red, so it is erythematous. So also in eczema, the skin lesion is going to be erythematous, but there will be some signs of edema or swelling. Edema doesn't necessarily mean that lower limb edema we talk about, but edema simply means swelling actually. But also vesicle formation, there can be a process of vesicle formation, like we say, we define the word vesicle. There can be exudation, and if you remember, when the exudate comes out, when the vesicle ruptures and the exudate comes out, when the exudate comes out, will dry and form something called a crust. So these are typical features of eczema. So normally eczema, the other issue that is present is itching. One will always feel the urge to scratch himself, the thing that we call pruritus in dermatology. So what causes or what induces this process is normally, it can be internal process or an external process. For example, when we were in primary school, I remember in boarding primary school, there are some people who used to wet their beds. They urinate on their beds. So normally what we did, early in the morning, if you find that someone has wet his bed, you take a poison ivy, a plant called poison ivy, or in Kiswahili commonly known as upup. You take that upup, you put on someone's skin who has wet his bed, and the skin will be itching. So through this process, we can say that the phenomenon that induced was an external factor, so we call it extrinsic. But if the factor arises from internally, for example, some people inherit from their family some disorders that are going to induce this systemic, to induce this pruritus and this phenomenon of inflammation of the skin. So if they arise from internally because of a genetic predisposition, then that is, the inducer is arising from within or systemic. So the hallmark of all this, the skin will be inflamed, one will try to scratch himself, but finally at the end of the day, the skin is going to harden, and normally this is called lichenification as we defined it in the secondary skin lesion. So here it is an example of trying to explain the exogenous and the endogenous, and if you remember, exogenous, we said those external factors. For example, allergic contact dermatitis. If you come into contact with something that you have allergy against, then that is an external factor. But if something is coming from within, for example, if you are having a familial healing, you're having a familial disease, for example, people who have asthma, they are having an internal genetic disease that induces inflammation, and this inflammation can be induced on the skin. So this is something that is within inside someone, and it's called endogenous dermatitis. It causes atopic dermatitis. So eczema or dermatitis can have two forms. It can either have acute or it can be chronic. And the easiest way to differentiate acute from chronic is normally acute is going to be wet, while chronic is going to be dry. So as the name suggests, chronic is going to have all features of acute, but is going to be having less edema, less vesicles, and less exudates. And normally lichenification is going to be present. On the contrary, acute is going to be having papules, vesicles, and occasionally bulle. So note the word papule, vesicle, and bulle. And there might be edema, erythema, exudation, fissuring or excoriation, and sometimes scaling. Hope you remember the definition of scaling, which is peeling off the skin. So these are going to be present in acute, but the chronic one is going to, normally the hallmark is going to be dyspigmentation. Either the skin will be lichenified with hyper or hypopigmentation. When we talk about pigmentation, means the pigment is that color of the skin. If the color of the skin changes and it becomes too much pigment or too much color as compared to the surrounding skin, then that is hyper. If the color is lesser, then that is hypopigmentation. Now let's talk about some disorders. Now this word eczema or dermatitis was a general term, but there are some disorders that we need to talk about. For example, atopic dermatitis. As the name suggests, atopic dermatitis or atopic eczema. Atopy, normally atopic or the atopic state. You remember even when we talk about asthma, we talk about this word atopy. When one is having a genetic disorder to induce an allergic reaction, we call this an atopic state. So people who get atopic dermatitis are those who have that inner characteristic of inducing an allergic reaction and causing either asthma or allergic rhinitis, including atopic dermatitis. So this is like a triad. If you see someone is having asthma, comes to the hospital complaining of a skin lesion that is itching, most likely that is going to be an atopic dermatitis, because this patient falls in this category of an atopic state. So the clinical features of atopic eczema is divided in different age groups. There is that for the infants, there is that for the childhood and adolescents, and that for the adult variants. Now, because in internal medicine we don't talk much about the infants, let's concentrate on the clinical feature of a childhood or adolescent. And normally this affects the fractural, the flexor areas. Now, where you are, you can try to touch the flexor areas on your body. So if you are trying to catch your knees, that's wrong. If you're trying to catch your elbow part, that is wrong. Those are called extensor surfaces. So the opposite are called the flexor surfaces. So the common area where atopic eczema normally affects the fractural areas in childhood and adolescent. However, in adult, the pattern might change and end up into lichen simplex chronicus. So as you can see, this area has changed. It is hyperpigmented. As you can see, the color here is not the same as the color here. This color is too much pigmented, so it is hyperpigmented. And the other issue is, you can note, is it's like this skin has been lichenified. If you try to catch, if this patient comes to you and try to touch this area, you find this area has been thickened, it's rough, it's having scales. So any hyperpigmentation, any scaling, if you remember, is the hallmark of chronic eczema. So this is a chronic atopic dermatitis, because it's dry, it's not wet. So coming to the treatment, so the treatment normally of this atopic dermatitis is divided into non-pharmacological and the pharmacological management. If someone is is having this disorder will need education and explanation. But if he comes into contact in different irritants, for example, he uses a lot of medicated soaps, he lives in areas with extreme temperature, you need to advise this patient to run away from this environment. But the other issue is avoiding the irritants or allergens. But the other issue that you'd want to use is to use emulsifiers. Very important concept, emulsifiers. So look at this skin. This skin is very dry. This skin is very dry. So this patient is going to need something that will try to lubricate his skin, to make his skin soft. And these medications that we use to make this skin soft are called emulsifiers or skin moisturizers. So in pharmacological management, the mainstay of managing patients with atopic dermatitis. Remember, this is the treatment for atopic dermatitis and not for the every dermatitis. So in atopic dermatitis, what we normally use is either use a topical antihistamine, or for example, cetirizine is the commonest topical antihistamine. You can give it per oral, or you can give some topical. We can give some topical antihistamines. They are present in market. But if you can't use these, anyway, these first three options are called oral antihistamine. They are oral antihistamines. But you can also use topical medication like steroid medication, for example, hydrocortisone ointment, 1%, and if the disease is mild, but betamethasone varenicate 0.025%, 12 hourly for 2 weeks. Remember, the percentage matters. We shall be talking about these topical steroids in the next few slides. So you remember my story about primary school, the use of poison ivy or upub will induce contact dermatitis. So anything that comes into your skin and induces an inflammatory reaction, that is called contact dermatitis. So anything can be an acid or base, and normally the skin lesion, if it is an acute contact dermatitis, it is going to be wet and edematous, but in chronic dermatitis, it's going to be dry, thickened, and scaly. Going to be having scales. Hope you remember the definition of a scale. So the diagnostic criteria for contact dermatitis, it needs one to be coming into contact with something that can came into contact with something that elicited an inflammatory reaction on the skin. Otherwise, the clinical features for contact dermatitis are almost the same. So the treatment of contact dermatitis, for example, you touched you inserted a catheter, foray catheter. Some people are allergic to those foray catheters. You insert a foray catheter to a patient, it induces a dermatitis reaction. Then the treatment is going to remove that allergen, which is the foray catheter or the urethral catheter, and to initiate betamethasone varenicate in case the area that has got skin inflammation can be applied with betamethasone varenicate cream. Otherwise, you can use oral steroid if you can't use the topical steroid. The other spectrum of dermatitis that we have is called seborrheic dermatitis, and seborrheic dermatitis is not a new term. I remember to have taught you HIV/AIDS in level 5 semester 2, and we talked about seborrheic dermatitis, and it was one of the opportunistic infection in HIV/AIDS stage 2. So normally this seborrheic, as the name suggests, seborrhea means oil. Seborrhea means oil. So it is inflammation of the skin that is characterized by oil. We can define it as that way. Otherwise, seborrheic dermatitis is a common chronic disorder characterized by grease scales. Underline this word grease. Grease means oil and means seborrhea, and there are scales that are going to be present. And normally, the cause of this seborrheic dermatitis is fungal infection. And as you know, fungal infection never affect people who are immune competent. Normally, fungal infection affect an area where there is immunocompetence, like in HIV/AIDS, like I'm trying to explain here down below. So the common areas that seborrheic dermatitis normally present is the area that are full of oil. For example, on your face. So for example, if you don't paint oil in the morning, in the afternoon you might find your skin is having oil. So those areas that are your face normally, those areas that are rich in oil are the ones where seborrheic dermatitis normally affect. These common areas include the nasolabial folds. I hope you know the nasolabial folds. This area here are the nasolabial folds, and these are the areas that are commonly affected by seborrheic dermatitis. But seborrheic dermatitis can also affect the scalp and normally will present as severe dandruff. I hope you all know severe dandruff. Kama mba wa kichwani. This is seborrheic dermatitis that has affected the scalp. So the treatment of seborrheic dermatitis normally includes a raw potent topical steroid. We shall be talking about the potence. Potence in dermatology is very important. The potence of topical steroid is very important. For example, you can't use a high potent topical steroid on the face. You're going to burn your face. You need to use a raw potent. For example, this disease affects the face, so you can't use a high potent glucocorticoid. But the other medication that you can use is a topical antifungal agent, because we said this is normally caused by fungal infection. So you can use, for example, ketoconazole cream or ketoconazole shampoo if the scalp is affected. So as you can see, this is the face of a lady that has been affected by seborrheic dermatitis, and if you're not very careful, you will see some scales, erythema area. This area is erythematous because there is an inflammatory area going on, and these are the nasolabial folds. The nasolabial folds here are around the sliding from the nasal area to the labia area of the mouth. These are the nasolabial folds that are affected. So that was the very first disorder, which is eczema. We come to the second disorder called vitiligo. Please be careful how I mention this word. It is not vitiligo, it's vitiligo. And vitiligo is an hypopigmentation disorder. We have so many hypopigmentation disorder. For example, people get mba kwenye ngozi, and these mba kwenye ngozi, they are normally hypopigmented. So take note, vitiligo is also an hypopigmentation disorder, but you shall be talking about this disorder. Yes, hope you identify who is this man. So the first thing to note is not on this patient nose. The nose is hyperpigmented as compared to the skin lesion. So this area here has been hypopigmented, and this is a disorder that we call vitiligo. Now, vitiligo, this man is, hope you all know this man. This is famous Michael Jackson. He had a disorder called vitiligo. You have all read about his story. And if you have not read it, please go to the internet and search about his history and how he came to bleach up his entire skin because of this body disorder. So let's talk about vitiligo. Remember, it's not vitiligo, it's vitiligo. It's an acquired condition affecting 1% of the population worldwide. So it affects 1% of the population. And the focal loss of melanocytes results in the development of patches of hypopigmented region. So remember, a macule is less than 1 centimeter. Circumscribed flat area with color change. But if it's greater than 1 centimeter, then we are talking about a patch. So in vitiligo, one will be having a patch. So patches of hypopigmentation. Hope we are together. Now let's talk about pigmentation. What gives you the color of the skin? The color of the skin normally originates from cells that are called melanocytes. Melanocytes are able to synthesize melanin, and melanin gives you the gives you the color, your color of the skin. So if melanocytes are damaged because of immune reaction, the melanocytes are not going to be able to produce the melanin pigment, and therefore you are going to be hypopigmented. So melanocytes are damaged through an autoimmune reaction. Auto means self, so it's a self-immune reaction. The immunity is fighting against its own cells, fighting against its own melanocytes, and melanocytes become damaged. Now here it's very important to remember that vitiligo is not the same as albinism. This is not albinism. In albinism, you lack the melanin pigment because there is an error during the production. But in vitiligo, the melanocytes themselves are dead, while in albinism, the melanocytes are alive. They are alive, but they cannot synthesize that melanin product. So remember the difference between vitiligo and albinism. All effects are related with melanin, but there are some differences. So to remember is you can have generalized vitiligo, but you can also have segmental vitiligo. In generalized vitiligo means the entire body is affected, while in segmental it's a simple region. It can be around the mouth. Different people, many people over the internet, if you happen to search, you'll find out that many people have vitiligo, vitiligo in celebrities. Many people have vitiligo. It's very important you know this. Very important you know this disorder, because you will meet different people, and many people, when see these people with vitiligo, they think these people have been burnt. They sustained a burn injury. That's not true. Vitiligo is just a disorder where the immune cells, anyway, my internet connection is very slow. Hopefully I'll come to the image when it has been displayed. For the time being, let's proceed with our presentation. So the treatment normally of this vitiligo is going to involve different approaches. For example, Michael Jackson opted for bleaching the entire skin. For ladies, you might be knowing this compound called hydroxyquinone. Hydroxyquinone is banned by the FDA because it contains some the compound hydroxyquinone can cause skin cancer. Ladies use this compound to bleach their skin. Beware, don't use this. Use it when you have some other disorders like vitiligo, to bleach your entire skin and look very well. High potency topical steroid can also be used, but the other method that is probably not present in our country is to use the ultraviolet therapy. Now, the use of ultraviolet therapy is, what you do is, in segmental vitiligo, when the certain segment of the skin lacks melanocytes because they are dead, you can use ultraviolet radiation to induce too much production of much more melanocytes. Like assume the ultraviolet radiation can make your body produce too many cells and cause cancer. So through ultraviolet rays, you can make these rays make melanocytes proliferate too much so that they can try to cover that part that has been breached or that has been hypopigmented because of the death of melanocytes. Hope you understood this concept of the use of ultraviolet radiations. So remember, throughout this topic, we have been talking about potency of topical steroids. Even in vitiligo, you can use high potent steroids. Now, just a reminder is, the use of steroid in vitiligo is not that the skin, if Michael Jackson ever used a high potent steroid here, the skin color would never return, but the use of steroid would prevent, the use of steroid on this area would prevent the progression of the disease even onto the nose. So if someone is having a segment being affected with vitiligo, he can paint steroid on the other parts so that the disease does not progress further. So these are the potents. We have a very potent, we have potent, we have diluted potent, we have moderated potent, and we have mild potent. For example, in vitiligo, we can use a very potent clobetasol propionate 0.05. Remember, the percentage matters a lot. For example, here potent 0.1 percentage betamethasone valerate, and diluted potent 0.025 betamethasone valerate. Remember, hydrocortisone was used in acne that affect, in the disorders that affect the face. If the disorder affects the face, then you need to use the raw potent steroid, 1% hydrocortisone. Now let's talk about the commonest disease that affect many people in the adolescent age. Especially ladies are affected with chunus or acne. Shall be talking about why this. So acne vulgaris is a chronic inflammation of the pyrosebaceous unit. Remember the pyrosebaceous unit? It comprises of the hair follicle together with the sebaceous gland, sebaceous duct where sebum comes out to the skin. So the condition is extremely common. It generally starts after puberty, and there are reports of it affecting over 90% of the adolescents. So you can note that it's a huge burden to the community. About 90% of the adolescents are affected. It's usually most severe in the late teenage years, but can persist into the 30s and 40s, particularly in females. Like I said, females are more affected by these disorders. Now, the pathogenesis of acne, first thing first, is, remember, we have sebaceous gland, we have a sebaceous pyrosebaceous duct where this sebum comes out to the skin, but you also have the hair follicle. So if too much production of sebum occurs, automatically you are going to have acne. But the other issue is that induces acne. Why should you get acne because there is too much production of sebum? It is because this sebum is going to block. It's going to block this duct, and if it blocks the duct, it means that you are going to induce an inflammatory reaction here in between. But remember, the other phenomenon that needs to be present is that some bacteria will colonize this blocked area. So it becomes blocked, the area becomes colonized, and after it has become colonized, it induces an inflammatory reaction, and one gets what we call acne. So the pathogenesis of acne goes through 3 stages. There is increased production of sebum, there is occlusion of this duct, and there is colonization of this pyrosebaceous unit that by a bacteria that is going to induce an inflammatory reaction, and yes, one gets acne. And here is the summary of what I'm trying to explain. So what is that bacteria? It is not every bacteria. It is P. acnes, Propionibacterium acnes. Is a bacteria that normally colonizes this pyrosebaceous unit and brings about acne. So you remember we discussed about this open comedon, but we also discussed about the closed comedon. Now look at this part of this pyrosebaceous unit. You might notice that it is underlined by a layer of epidermis. This purple part, this is the layer of the epidermis. This layer of the epidermis, you remember, it produces keratin. So keratin will also be shed out through this epidermis. And this area that surrounds this area, keratin will be produced by these cells and will be dumped out to the skin. Now, assume now there is occlusion or there is blockage of this duct. What is going to happen? Keratin is going to remain inside this pyrosebaceous duct. But at some chances, this keratin together with sebum can come to the top because it is only the top part that has been blocked. Now, it will just depend. If keratin comes to the top, means it will come into contact with the hair. If it comes into contact with the hair, keratin is going to be oxidized, and the comedone or the skin lesion that will appear here will have a black color because keratin together with sebum, when they become oxidized, they transform into black. So we get a black head comedone. And when occlusion is deep inside this duct, means keratin is not going to come into contact with the hair outside there. So keratin will maintain its color. So this comedone, when the inflammation has occurred and the skin has swollen, this comedone is going to appear white in color. So we have a open comedone, but we also have a closed comedone. So the typical skin lesion in acne is a comedone, but one will also present as having an inflammatory papule. Remember, bacteria induces an inflammatory reaction. So one will have a papule, and I hope you remember the definition of a papule. In some people, the papule will proceed into a nodule, and some people will also have cyst, and these cysts normally arise from these comedones. In some people who have been suffering from acne for a long period of time, their skin is going to change. It's going to have scars. They will also have present with scarring. We shall go to see some pictures. As you can see, this red here, as you can note here, you can see some changes in the color pattern. This skin is being scaring. It's getting scars because of too much too much attack of acne. So as you can see, this is a papule, but as you can come to this lady is having a very severe disease of acne, needs help actually. So you can see these are sort of like cysts, because in acne, if you try to press this skin lesion, there is something that is going to come out. It's a semi-solid stuff. Some ladies have to burst these chunus. So if they burst them, there is a semi-solid stuff that comes out. So remember the definition of a cyst: the encapsulated skin lesion with semi-solid contents. So acne has different. Remember, here we're talking the normal acne that we talk about is acne vulgaris, but there are some other different forms of acne. You have acne conglobata. In acne conglobata, one is having nodular cystic lesion. As you can see, this person is severely affected with nodular cystic skin lesion. Now, someone with such type of acne, this is called acne conglobata, composed of comedones, nodules, abscess, sinuses, cysts. But one can also present with acne, but together with systemic inflammation. Maybe presents with fever, arthralgia. If you do the full blood picture, you find that the white blood cells are elevated. And this type of acne is called acne fulminans. But you also have acne excoriae, and in this, normally it's like a psychological problem, and one normally feels that he's having acne, so we normally try to scratch his face and end up getting excoriations. This is called acne excoriae. But there are some other causes of some other causes of acne. For example, if you use oral contraceptive pills, you might get acne. If you have a disorder called polycystic ovarian disease, it will manifest with acne, so that is normally called a secondary acne. Hope we are together when we talk about the secondary acne. Some people use greasy cosmetics. Too much cosmetics with too much oil will give you acne. Remember, too much oil is not needed in your skin. So we have a non-pharmacological management, but we also have pharmacological management. So acne is divided in 3 types of severity. We have mild to moderate acne without scarring, but we also have moderate acne. So when one is having mild to moderate acne without scarring, means he's having comedones and there is no scarring on his skin. For example, if you look at this lady does not have any signs of scarring. This one probably has some scarring, and the other lady that I showed you earlier, this lady has some sort of scarring. Is having some scars. So if one has acne and there is no scarring, that is mild to moderate, and normally one will need to use benzoyl peroxide. Benzoyl peroxide is available even in our market at 5%, and you can also use retinoid 0.05 once before you sleep. You need to use it during the night before you sleep because this can burn your skin. You don't have to use during the day. But if someone has scarring, like the one that I've shown you, this lady is having scarring with probably it's not that much. He's having mild, but he's having scarring. So if he's having moderate acne with scarring, we'll need to use an antibiotic together with a benzoyl peroxide or a topical retinoid. Remember, acne pathogenesis involves a bacteria called P. acnes. So use of antibiotic is therefore explained. But in people who are having very severe cystic nodule, like this is a nodule, cystic lesions, these people are going to use medication called isotretinoin, and all these medications are available in the market. People with acne fruminans, remember those people with the acne but they present with systemic inflammatory condition like fever, joint pains, elevated white blood cells, they will need this medication including prednisolone. But remember, why ladies get too much of acne is because of the hormone. So the use of oral contraceptive device can give benefit to some people, but again the use of COC can also cause a disease in someone who's not having acne. So remember, some hormones produce too much sebum, that's why females are prone to this, and the use of these hormonal contraceptive pill can help in relief of this disorder. So the other disorder that I want to talk about is psoriasis. Please note how I pronounce this word. It's not psoriasis, it's psoriasis. So let's talk about psoriasis. Now, psoriasis is a chronic inflammatory skin disorder clinically characterized by erythematous, sharply demarcated papules and rounded plaques covered by silvery white scales. The typical psoriasis will have plaque with silvery white scales. Let me show you. You can see this area of the skin. This is of which color? It is silver in nature. It is a plaque. It is a raised skin lesion with a flat top. And in some forms of psoriasis, you will find some scales. For example, these are scales. Otherwise, if you zoom in your PC, you will notice that this is also a plaque. It is a raised part of the skin. It has been raised here, but the top part is flat and is also having scales. This is what is psoriasis. And we have different remember, psoriasis is a chronic inflammatory condition, and normally these skin conditions are pruritic. They induce a urge to scratch. So the commonest form of psoriasis is the plaque form. As you can see, this is a plaque. Again, it's present on the knees, and we call these the extensor surfaces. The knee is the extensor, while the popliteal region there back is the flexor area. Remember, the flexor area commonly affected by atopic eczema. So look at this child here. It's having some silver scales, some silver skin lesion on the back, and this is another form of psoriasis called guttate. And normally this guttate psoriasis follows a streptococcal infection. The same way one gets rheumatic heart disease is the same way one will get guttate psoriasis, is through the upper respiratory tract infection. Some psoriasis is going to be erythrodemic, means the skin is erythematous, but some other forms of psoriasis can also have pustule instead of the typical one that normally has plaques that are silvery in nature. So normally psoriasis complicates into a disease called psoriatic arthritis. We shall be talking about arthritis in the subsequent chapters. So remember, it's one of the complications. Inflammatory erythropathy or psoriatic arthritis is one of the complications of psoriasis. The investigation, because sometimes it might be very difficult to come up with the diagnosis of psoriasis, one will need a skin biopsy. But in children who have guttate psoriasis, you might want to take a throat swab so that you can rule out the streptococcal infection. When you come to treatment, the mainstay of treatment is use of sun exposure in non-pharmacological management. The sun exposure tries to suppress the chronic inflammatory process that is going on in these people with psoriasis. But the other medication that you can use is crude coal, 5%, and you mix it with Vaseline in the morning. But because this psoriasis is dry, you will need a emollient. This emollient will include salicylic acid to try to moisturize that area that is dry. Because it is an inflammatory process, you can use betamethasone or ointment in the evening. The other treatment that we can use is ultraviolet therapy or phototherapy, probably not yet employed in our country. But the other medication, because these are chronic inflammatory condition, you might want to use strong immunosuppressants. For example, methotrexate, cyclosporin. And these days of coronavirus or COVID-19, you might have had a drug called hydroxychloroquine. Hydroxychloroquine is also an immunosuppressant and is also used in dermatology, especially in the treatment of psoriasis. Last but not least, the disorder that you probably know about is Kaposi sarcoma. Kaposi sarcoma or KS. KS is the skin cancer. As you can see from this diagram, these are the typical skin lesions that are present in Kaposi sarcoma. And you can notice the typical color of Kaposi sarcoma is going to be purple in color. So if you examine the whole palate of someone and you find a purple color like this one, this is Kaposi sarcoma. This is Kaposi sarcoma on the lower limbs. So Kaposi sarcoma, why is it called Kaposi? It is because the dermatologist who first explained this disease in 1872 was called Moritz Kaposi. And this disease was rare until when HIV/AIDS came in. And as if you remember, HIV/AIDS in stage 4, one might get Kaposi sarcoma. But Kaposi sarcoma is also present in homosexual people and in those who are not even involved in epidemic. But the other issue to remember is Moritz Kaposi was first diagnosed in European countries, and normally this was called the classic Kaposi sarcoma. So we shall see different names. Initially it was called classic Kaposi sarcoma because it was having the typical feature. One is not a gay, one is not having HIV/AIDS, one is not an African person, but is having Kaposi sarcoma. It was called classic Kaposi sarcoma. The commonest virus that causes Kaposi sarcoma is called human herpes virus type 8 or HHV8, and if you take biopsy from this individual having Kaposi sarcoma, normally you will also identify that these biopsies will also contain this virus, human herpes virus type 8. So we have the classic Kaposi sarcoma that was very first identified in European people who are not having HIV/AIDS. They were not involved in homosexualities, and there came in the the African Kaposi sarcoma, and in African or endemic Kaposi sarcoma, one was not of European descent, but was an African, was not HIV or was not immunosuppressed, and he was not even a gay, but he was having Kaposi sarcoma, so they named it the African or the endemic Kaposi sarcoma. They all have different explanation, and I leave this as part of your work to read at home. You read through and identify other differences apart from the root cause. But the other form of Kaposi sarcoma is that one that normally affects people who are on immunosuppression after a organ transplant. For example, if you get a kidney transplant, you will need to use immunosuppression to suppress the immunity so that the body does not fight against this new implanted organ. So people with organ transplant, normally they are given immunosuppression, and they are at risk of getting Kaposi sarcoma. This is called immunosuppressive treatment related Kaposi sarcoma. And the Kaposi sarcoma that typically you know is called the epidemic Kaposi sarcoma, and normally this affects people who are having HIV/AIDS, and it is also sometimes called AIDS-associated Kaposi sarcoma. But you also have a non-epidemic, so it is not associated with HIV/AIDS, and it is common in people who practice gayism or who practice homosexuality. So it is called non-epidemic gay-related Kaposi sarcoma. So for you to diagnose Kaposi sarcoma, because it's a skin cancer, you need to take a biopsy. Now, when you talk about biopsy, means you take a tissue from a human body and you take it for histological examination. The pathologist will identify that this tissue, if it was taken from the skin, then it does not resemble the tissue from the skin. It is probably a malignant tissue. So this is what we talk about skin biopsy. So we use skin biopsy to diagnose Kaposi sarcoma. The other thing to remember is normally people will present with Kaposi sarcoma in the lower limbs. But if you find Kaposi sarcoma on the hard palate, then that is a systemic Kaposi sarcoma. Means it has disseminated to the whole body. It can involve the lungs, it can involve abdominal organs, so you need to take chest x-ray, you need to do abdominal ultrasound in some people who have systemic Kaposi sarcoma. And people in whom you suspect Kaposi sarcoma are those who will be having red or purple skin lesion on the hard palate. That's why I normally insist about examining the hard palates of people who are having HIV/AIDS. So we forgot to talk about the clinical typical feature of Kaposi sarcoma. Normally, the patient will present with either red or purple or a browny patch. It can be a patch, but it can be a plaque, or it can be a nodule on the skin lesion or on the mucosal surface, and it can disseminate to all parts of the body, and it's called systemic Kaposi sarcoma. Treatment. The mainstay of treating Kaposi sarcoma is using radiation therapy and chemotherapy. As you know, in our country, radiation therapy and chemotherapy is administered at the Ocean Road Cancer Institute in Dar es Salaam. But if someone is having AIDS-associated Kaposi sarcoma, if means is in HIV stage 4 with Kaposi sarcoma, And normally the best ART or the antiretroviral therapy that is preferred in people who are having AIDS-associated Kaposi sarcoma is a protease inhibitor. Remember, what causes Kaposi sarcoma is also a virus, so also using a protease inhibitor can be very, very efficient in suppressing the virus. So this is the end of the dermatological condition that you are supposed to study in NTA level 6. And after the end of this presentation, I'm going to submit an assignment. I'm going to give assignments, and these assignments will be posted in Google Classroom. Now, each assignment is going to be having a deadline. One will need to submit this assignment, and one will need to add or create an answered document in Google Classroom. I'm going to show you this. And after you do your assignment, you're going to press turn in. When you press turn in, it means you submit your assignment. Now, let's jump into Google Classroom. I'm going to invite all NTA level 6 students for participating in Google Classroom. Remember, this was for showing you vitiligo in some celebrities. Now, for example, this is one of the assignment that was posted today by Dr. Joel, who is our principal. So this is the assignment. You can click it. You can come here at the classwork in Google Classroom. You can also install Google Classroom application in the Android smartphone. It's unfortunate that my internet connection is having some problems, but anyway, let me try to explain using these examples that are present. So for example, if you find such a multiple choice question, you read a question, you find the answers, you can comment, but you need to select an answer and press turn in. If you press turn in, it means you submit your assignment, and we shall grade you accordingly. You can see your points. For example, if you score this, then you will be given 100 points or whatever the teacher will have put. And if you miss the question, one will write here that you missed this question. The correct answer probably is your teacher is going to do that. And for the document, for the assignment that will involve typing, you will need to go here and view the assignment, but you will come here on your work, you add or create, you select Google Documents, and the Google document will be created here. You enter this Google document and type in the correct answers for this assignment, and after that, if you open Google Docs, you will find a word written on turn-in. If you press on turn-in, it means you submit this assignment to a teacher. But you can also use, your teacher can grade your assignment. For example, this assignment was graded 20 out of 100 after I submitted it. So if the teacher tells you to repeat this assignment, then you need to add or create a new document here, and you need to submit it. Hope everything is clear. Any questions will be questions will be accepted, will be welcomed as we continue with this training. And in this PowerPoint, I'm trying to show you how you can upload. You can answer this assignment here in your PC or in your phone, and you can come here and upload your file through the file attachment, or you can type your assignment online using Google Docs. Even if you are offline, you can type it and switch on the internet and submit it to your teacher by submitting the turn-in button in Google Docs. Hope this marks the end of the presentation in dermatological condition. See you next time. The questions will be posted in Google Classroom, and the teacher, me, I'll be there to help you whenever you are stuck. Thank you very much.